All right, guys. So I posted on Thursday a lecture for you guys over the hip. So just basically an intro to the hip. Tried recording this twice last night, but it did not work out, unfortunately, the way that I had hoped. So I'm re-recording it today. All right. So okay. So hip and pelvis, right? Here we go. Obviously, what are we going to be doing when talking about the hip and pelvis, right? So first and foremost, we want to clarify, right, the presentation of someone that presents with hip pain, right? So ultimately, when we use the term hip, we're talking about the term hip, we're referring to the coxifemoral joint. Okay, so the junction between the femoral head and the acetabulum. Okay, that is what we mean by hip when we say hip. However, what you'll find often in patients that are coming to you telling you that their hip hurts, right? Generally, you may have to kind of deduce whether or not it's buttock pain or whether it's like SI joint pain, right? So it's really important to make that distinction when talking with patients. But it's really important also, right, to having knowledge of how the hip develops not only in utero, but also throughout childhood, because there actually is a direct relationship between childhood hip pathology and adult pathology, right? One of the most common presentations of this phenomenon is actually a disorder called hip dysplasia, right? And so those are things that are very, very much related. So ultimately it presents as something that occurs during childhood, but then is not necessarily picked up on until adulthood in some cases, because it's often misdiagnosed. One of the things that we're also going to learn and or lean on very heavily when talking about the hip is obviously not only the physical exam, right, but learning a little bit about how to read plain radiographs of the hip and pelvis, right? And the reason why that's important is, first and foremost, we have to make the decision, right, when seeing a patient with hip pain. Is this acute pain, right, where it's generally maybe more muscular, right, only going on for maybe a few days to a week, or is this pain that's been there for a very long time, 6 weeks or more, and is it at that point when we consider doing an X-ray, right? And so kind of having to, make the decision of when to X-ray versus when to, leave it alone. It's fine, not X-ray, right? And so those are things that we'll talk about. And then obviously we'll get some skill practice in as well and go over some cases. So what is the hip anatomically? So as we've already said, anatomically, the hip is defined as the coxifemoral joint, okay, or the articulation between the femoral head, right, and the acetabulum of the pelvis, or the hip socket, right? So the acetabulum forms the socket of the hip, right, at the lateral aspect of the ilium, and the head of the femur forms, and that obviously makes the ball of the hip. But it is that ball and socket joint that makes possible movements like hip flexion, hip extension, okay, abduction, adduction, and then internal and external rotation of the hip. So one of, kind of a complicating factor, right, in diagnosing hip pain and groin pain is the presence of the musculature around the hip, right? So the iliopsoas, the adductor group, okay, the brevis, longus, and magnus. And many times, injury to the muscular structures can actually produce groin pain, right? So as we talked about, and as we've kind of been, learning throughout the course of the year, that, we live our lives in this trade-off between mobility and stability. So unlike the shoulder, which is a ball and socket joint that I know the juniors have learned about, right? The shoulder is extremely mobile, but very unstable, right? So usually the more mobility something has, the less stable it is, okay? However, with the hip is inherently very, very stable because it's deeply recessed inside of the pelvis, right? But it is relatively much less mobile than the shoulder, right? Which is another ball and socket joint. Okay, so embryologically, right? Here we have obviously the femoral head, And we can see these primary ossification centers, obviously at the femoral head, and then also, and then also at the physis. So we have the femoral neck, the greater trochanter, and then our down here would be the lesser trochanter, which we don't see pictured here. But over here on the right side, this is the triradiate cartilage, okay? And it is this cartilage that develops embryologically and becomes the bony acetabulum, okay? The bony socket of the hip forms from the triradiate cartilage. When we are children, when we're young, right, our bones are mainly cartilage and they're not entirely ossified, right? And so generally speaking, the forces that we place across the hip joint itself during weight bearing directly affect not only the shape of the femoral head, but the amount of coverage that, excuse me, the amount of coverage that's present in the socket. So for example, here's the ball, here's the socket, right? And in a normal developing person, there will be, just a very nice kind of symmetric balance of coverage of the acetabulum over the socket to create that stability in the hip, right? However, as we're going to see here in a minute, there is essentially a time where someone will develop essentially under coverage of the acetabulum, okay, and that's known as dysplasia, and the hip can become unstable. Conversely, we can have too much over coverage, right, of the ball of the hip or the femoral head relative to the acetabulum. We can develop impingement, right? Okay, so the muscles here, right? So as we've already talked about, and we'll learn more about this, a good majority of the time, probably 70% or more, if someone comes into you and they're presenting with acute hip and groin pain with a mechanism, generally speaking, it's safe to, have a high index of suspicion clinically for muscular injury, right? And generally speaking, the muscle groups that are going to be involved are going to include the iliopsoas, the hip flexor, right? The adductor group, be it magnus brevis or longus, and sometimes the gracilis and the sartorius. So really important to note that within the hip itself, and we will point this out, okay, in class, we actually have a structure known as the femoral triangle. And within the femoral triangle, we have highly, highly important neurovascular structures, being the femoral artery and vein, okay, as well as the femoral nerve with its associated branches. So once the femoral vein and the femoral nerve descend about past the point of mid-thigh down toward the knee, they then actually become the saphenous nerve, right, which innervates essentially the medial aspect of the thigh distally, kind of near the VMO, the vastus medialis. Okay, here it is though. Here is the mature hip, the ossified hip, right? Excuse me. We can see anatomically that we have the femoral head, we have the greater trochanter and the lesser trochanter here, right? And as we can see, here's the ilium, okay? So we have obviously the ASIS, PSIS, acetabulum, okay, pubic symphysis down here, and then the ischium, right? So here's the deal, right? As we talked about, it's really, really important to develop an appreciation and an understanding of the full spectrum of hip pathology from the time we're little until we're adults, right? So ultimately, there are developmental differences in the way the ball and socket are shaped and develop as people, grow and mature. And those differences in size and shape, right, that is referred to as the morphology of the bone, right? So the morphology, the size and the shape, right? And the change in that size and shape, right? And so here in a second, we're going to see an exam on an infant with hip dysplasia, right? I think that's the next slide. So ultimately, it's extremely important to identify, hip pathologies in children, particularly hip dysplasia, because, right, we can actually manage this in kids, right? And decrease the incidence of, hip pain, hip discomfort later in life, as we'll see here in a second. So, so that's the importance. They're in a baby picture there. It's the importance of getting this right and understanding the disease spectrum, particularly in little human beings, right? Okay. So, little video here that I want us to watch. Okay, and this is actually a hip exam in an infant with hip dysplasia. All right. And you'll notice here on the right, the infant's right side, this is the dysplastic hip. And so we're going to watch this exam. This is actually really interesting.
I'm Scott Rosenfeld, a pediatric orthopedic surgeon at Texas Children's Hospital and the director of the hip preservation program here at Texas Children's. Today, I'm going to demonstrate how to do a baby hip examination. This is important for primary care providers to understand so that these developmental hip conditions can be recognized and treated early. Mom, why don't you go ahead and place her down on the examination table? Thanks. And then you can stay close to her so she feels secure with her. So I usually do this examination with the baby either supine on the examination table or sitting on mom's lap, whatever they're more comfortable doing. But as long as the family's close, they're generally a little bit more comfortable. And so I start out by trying to get them to relax their legs a little bit and bring them up into this flexed position. And I start by abducting both of the hips, and I want to look for symmetric hip abduction. That's abduction of the bilateral hips. And you can see on her, both of her hips abduct the same amount. And then I bring them both up together and I do the Gallioxy test. And I'm looking for knee height. And you can see how the right knee is a little bit lower than the left knee here, which suggests that this hip might be dislocated. And then again, I'll bring them into abduction. And then I'll do my Ortolani and my Barlow test. So on this hip here, the left hip, I'm holding the knee and I'm going to examine one hip at a time. And I'm going to bring the left hip into adduction, and give it some posterior stress to see if I can move it out of the hip socket. And that would be a Barlow exam. And that was a negative Barlow exam. And then the Ortolani exam is the opposite, where I abduct it and I lift up on the trochanter to see if I can put a dislocated hip back into the socket. And this is a negative Ortolani exam. And so now I'm going to do the same exam maneuver on the right hip, where I'm going to do a Barlow test. I'm going to adduct it. And there, it dislocated out the back. So that's a positive Barlow exam. And then the Ortolani is the opposite, where I lift it up and it pops back in. So positive Barlow out, positive Ortolani in, Barlow out, Ortolani in. And you can see how it's not uncomfortable for her. It doesn't cause her any pain. And those are the basics of the hip exam in a baby.
All right. So, right, guys, as we saw, that is actually an exam on an infant, right, with hip dysplasia. So, with the exam there, we got the Barlow test, which is a posterior dislocation of the hip. So that click of exit, we saw the hip dislocate when he adducted and translated that greater trochanter posteriorly. And then the Ortolani exam, when he abducted the hip and attempted to lift the trochanter anteriorly to get the hip back in, right? And one thing that you noticed here, excuse me, is that those maneuvers are not painful for the baby because, right? Remember, we still have a very flexible, very flexible triarticulate cartilage and a very flexible femoral head. So it's not necessarily it is not ossified, right? And so one thing that we'll also talk more about, particularly in pediatric cases, it's very important to pay attention to knee symptoms as well that people might be complaining of, particularly if on exam there doesn't really appear to be a difference, right? Or any positive findings on the exam. So in that situation, there are a couple of pathologies where this is relevant. One of them is dysplasia, right? And so because the femoral head was actually translated posteriorly, it actually caused an apparent difference in femoral height, right? So it made the femur look shorter on the side which the hip was dislocated. We'll also see this when discussing a condition called femoral capital epiphysis and potentially leg calf Perthes disease in kids, right? So the reason why it's important to discuss these things in children is because all of them have their parallels in adulthood, right? So extremely important to get an understanding of these things in kids, little people, right? So that we can appreciate their parallels in the fully skeletally mature adult. All right, well, let's say that we have a little one with hip dysplasia. Here's why it's so important to identify it early. Excuse me. We can identify, or we can utilize a device called a Pavlik harness. And if we look at this here, we can actually see how the Pavlik harness essentially holds the infant's hip, and it looks kind of cumbersome, but it holds the infant's hip in a neutral position and allows the developmental force right between the femoral head and the acetabulum to essentially be distributed evenly right across the hip, and allows for then appropriate ossification, right, and development of the triradiate cartilage as it continues to ossify over the femoral head, right? So this is a very effective way of treating hip dysplasia in infants who still have obviously very soft, spongy cartilaginous bone. All right, so guys, so that's a quick introduction to the hip. We will obviously go more in depth into anatomy as well and talk about more conditions, but just to give you a little bit of an idea about how we're going to approach the hip. Hope you guys have had a good weekend, and I'm looking forward to this. Have a good day, guys.